Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsor, Aultman Health System. Today, Brad and I are broadcasting from the administrative office, and our guests are Dr. Robert Dallara, Dr. Sarah Rogers, both of Aultman Pain Management. Good morning and welcome to the show, doctors.
Good morning. Thanks for having us.
Thank you.
Aultman Pain Management offers comprehensive services to help patients manage chronic pain and improve their quality of life. They are a multidisciplinary team that includes board-certified physicians, physician assistants, clinical psychologists, advanced practice and registered nurses, physical and occupational therapists, dietitian, social workers, and pharmacists. We'd like to remind our listeners today our program is available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe today.
Good morning, Dr. Lara. Please tell us about your role as medical director with Aultman Pain Management.
All right. Well, good morning to you both, and thanks for having us. We're excited to be here. So my role as medical director for the Department of Pain Management is to make sure that we're integrating all of our facilities with the latest up to technology and date procedures that we can offer all the patients throughout Aultman Health System in our various locations. My role is to oversee further development and addition of extra procedures and facilitate getting the care for patients, as well as providing ancillary support for all of our staff regarding staffing and hiring of new employees and the like. So we're just excited to be growing tremendously as a system of pain management here at Aultman and better serving our local patients.
So Doctor, what do you specialize in?
So I am a specialist in pain management. I'm board certified in both anesthesiology and in pain medicine. To drill down a little further, I specialize in interventional procedures of pain management, more specifically minimally invasive type procedures. Basically, gone are the days of large back surgeries. If they are able to be avoided, we will do minor procedures that will help alleviate the suffering of those in chronic pain. We do multiple different types of injections and procedures, many of which were not even available as little as 5 years ago. But we offer all of those comprehensive therapies here along with my colleague.
So what is it really is pain management? Not only drugs, but whatever, I'm sure.
So chronic pain is a multidisciplinary approach to a condition that affects most Americans some point in their life. Chronic pain is the number one cause of disability in the United States. It can vary from multiple causes to etiologies, as well as the timing and how long the patient suffers from such a condition. So, pain management basically is the focus of how to fix or work on those types of conditions and do as much as possible to alleviate any suffering that the patients are experiencing during that time. Pain management focuses on a multiple disciplinary approach from, as your co-host had mentioned, psychology, physical therapy, ancillary services such as acupuncture and things of that nature, all the way to medical, which would include opioid therapy, non-pharmacologic therapy, non-opioid therapy, and the interventional therapies that I had mentioned.
Okay, good morning, Dr. Rogers. What is your role at Aultman Pain Management?
I'm a staff physician here in Massillon at the Massillon campus. I work 5 days a week here. I do almost everything that Dr. Dallara does. Same thing, interventional management of pain, as well as medication management, and offering the other therapies as well. I'm staff physician taking care of patients Monday through Friday.
Okay. Do you have a specialty that you focus on?
I mostly treat neck pain, back pain, and joint pain.
Okay.
Interesting.
So,
So, well, go ahead. I'm sorry.
why would a patient need to see a pain management specialist?
If the patient, we consider chronic pain as pain being lasting longer than 12 weeks. However, we see patients in acute pain as well. There's a lot of things that primary care physicians aren't comfortable treating with medications. That is our specialty, and that we trained in, and as well as the interventions. To treat pain management, the three options are surgery, interventions like injections, and medication management, and we contribute to the latter two.
So, Dr. Dallara, what do you need? Why do you need a referral from the primary care provider to be accepted in Aultman Pain Management?
So as we mentioned before, pain is a multifaceted approach, and it's very important to have all of the members of your healthcare team know that you're involved in pain management for multiple different reasons. But that way, at least from the get-go, the primary care provider who does most of your medical care is very aware that you're being treated by pain management. Also, it's very important that primary care, besides being aware that you're going to be with pain management, does some of the early legwork so that you get the most effective initial office visits and consultations so that we can quickly proceed to certain things without having to do some basic pre-work, such as physical therapy, x-rays, the like, when those are appropriate.
So, tell our listeners how to get a referral and what is the criteria for acceptance into Aultman Pain Management.
So basically, if you feel that you need to have a referral with your to pain management, you go ahead and talk with your primary care provider. If they deem that it's appropriate, then they will go ahead and send a referral over to us. At which point, again, we'll kind of look at the referral, make sure that the necessary things, like I'd mentioned earlier, like x-rays or physical therapy and the like, if appropriate, were done out of the way early so that we're not wasting time with a very simple visit to order some of those basics. After we ensure that everything has been completed, we'll have the patient fill out a very specific pain questionnaire so that we have a really good understanding of why they're coming in, what their goals are, what they would like to be helped with, what their thoughts are, because expectation sometimes doesn't always meet reality. And the closer that we can be aligned in that at the first meeting, usually the better the outcome. We'll call the patient, get you scheduled, and we'll have an initial office visit.
Okay, so once the referral is in, the next steps are.
So again, we will, look at the referral. We will make sure that the patient hasn't been established at another pain management facility. Make sure that, the necessary things have been completed, like we said. We'll also delve into the patient's prescription drug history and social history, make sure that they have not had any issues with drug abuse, anything like that. And then, make sure that they really weren't just, a patient here before, maybe didn't have an issue with a provider or something, and then go away, establish somewhere else, and come back. Now, obviously, we do understand that patients move around. Sometimes jobs are an issue, things of that nature. So every patient is looked at as a case-by-case basis because everybody is different and every body is different.
It is time for our first break. Thank you for listening to Health Matters with the Medicine Center Pharmacy today. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder to stop by the pharmacy and talk to a pharmacist about our Health Matters membership savings program. We want to help you stay well and save money as well.
Okay, doctors, I'd like you to take some time to talk about some of the different types of pain that Aultman Pain Management treats. I know you've already mentioned that each person and each body is different, and I'm sure that means you've seen hundreds of different types of patients with hundreds of different types of pain.
Yes, so we treat mostly what we call like axial neck and back pain, basically pain in the back of the neck that goes all the way down. It can be in very different places, but neck, mid back, low back pain. That pain can radiate to the arms, sometimes can radiate to the legs. We also treat joint pain, shoulder pain, sometimes carpal tunnel. We can do injections for that. Hip pain, knee pain, ankle pain, foot pain. We treat various types of pain, but the pain that we don't specialize in is migraine pain or headache pain. The neurocare unit tends to handle that, and as well as facial pain. And we also don't treat pelvic pain, abdominal pain, and testicular pain. Mostly that would be GYN or urology or a GI doctor who would treat that type of pain.
Okay. So you have a myriad of different treatment options. We touched on some in the opening, and can you talk about maybe what a garden variety approach is? I know it's very specific to different patients, but how do you begin to help someone?
So first off, we would start with our evaluation in the office, talking with the patient, doing our thorough history and a physical exam to come up with a diagnosis. Once we have a diagnosis for that pain, that basically changes the way we would treat the patient depending on what we think is the cause of the pain. So the treatment for different various pain problems would be, we could have interventional therapies like injections, such as joint injections, epidural injections, injections for arthritis, ablations, which is basically heating up the nerve so it doesn't conduct the pain signal to the brain. We also use TENS units, psychotherapy, medication management, which includes non-opioid and opioid medications if appropriate. We also use physical therapy, refer to physical therapy for dry needling or manipulation, osteopathic manipulative therapy. We also offer minimally invasive procedures such as there's a procedure called a mild procedure, which helps with stenosis pain, as well as stimulator, which is an implanted device that helps with chronic pain.
One thing that, as a pharmacist, I think I learned that was interesting when I think of pain management, I think a patient comes to see you and you're going to cure all their pain. But the reality is that your job, in my impression, is to do the best you can to help them manage pain sometimes, because you can't always help a patient be completely pain-free. Can you comment on that thought? Because I know patients patients expect a lot sometimes from you, and I'm sure it makes your job terribly difficult. But the reality is you can certainly make them and their quality of life more comfortable, right? But sometimes there's a little bit of give and take.
That's true. So we're called pain management. We try to help manage pain. Sometimes you can make somebody pain-free with the modalities as discussed before, but how I kind of discuss it with patients is we don't want this to be the focal center point of your life, pain. You might still have pain, but we have controlled it enough to the fact that it's in the back of your head. You can still do all of your things that you would like to do and have a good quality of life, and it's kind of in the background. Chronic pain is very difficult to treat, as Dr. Dallara was stating, that it's very widespread. It's the number one comorbidity in the population of the United States. So most people do have a component of chronic pain, especially as we age. That gets worse as our arthritis gets worse and our bodies kind of break down a little bit. But we don't want that to be the focus of your life. We want you to have a good quality of life and the pain be in the background. That's the goal that we have.
Interesting.
Okay. So patient, you've talked a little bit about some of the things you do. What can a patient expect on their first appointment when they come into pain management?
So basically, when they come in, we'll do a thorough intake with our nursing staff. We'll review all the medications. We'll look at therapies that they have tried and failed. We'll go over any and all available imaging with them, specifically to their pain pathology. And then, we will have a long drawn out discussion with the patient regarding multiple options. What we tend to try to do is we try to give them kind of the first step or short-term thought, what's available after that, what's available even after that. So, you kind of have this whole paradigm so that the patients don't feel like, there's one option, They're here, they were seen, what happened, and then they go away. That's not the way that we want to work and practice. We want them to feel like we're going to be alongside them the whole way, and that we have a very longitudinal course that we can use to treat them. And after we come up with that discussion and assessment, we decide what the next step is.
So, how often do patients come in for a follow-up care after their first appointment?
I mean, that kind of varies, between the physician and the patient. Certain patients have more difficulty coming in for things. Some are ride dependent. Some folks, don't want to drive in the snow. After all, it's Ohio. So we're willing to, try to work with them the best we can, as long as it's safe and we're working towards our treatment goals. Specifically, if you are going to be on the opioid type medications or the high risk medications, then we pretty much expect to see you monthly, so that we can continue to constantly assess, monitor, and reassess things that are going on with you, to make sure that that type of medication is still effective and that you're not experiencing side effects or anything like that. One of the unfortunities of medicine is that insurance gets to dictate a lot, as you gentlemen know, that, insurances sometimes will actually dictate how many procedures we can do on a certain area, how frequently, things of that nature. So sometimes it's part of playing that game, but also we just are trying to do the best we can with working with the patients while trying to optimize their medical therapy.
So, when does pain become chronic?
So as Dr. Rogers said, the general consensus is after about 3 months. Another way of looking at it is pain becomes chronic when it extends further than the expected time. So therefore, let's say someone has a surgery and an expected recovery time is 8 weeks, but around week 10, they're still experiencing pain. That would still actually meet the definition of chronic pain. So whenever it does exceed the expected time for healing, that would become chronic. But the general otherwise accepted course for something, let's say back pain, is about 3 months or 12 weeks. That's when pain becomes chronic.
I know individuals have, some of them have multiple pain sites or multiple pain issues. What's the game plan on how we deal with that?
So in general, when they come in, we ask them, if we're looking, like I said, we look into treating chronic pain. Are they a candidate for surgery? Yes or no? Interventions like procedures or injections, and then medication. So if their back pain is the worst, we'll talk about procedures or interventions for their back pain, but also medications can be able to treat their general body pain as well. So if a lot of times what happens is our brain kind of focuses on the worst pain. So we could have neck and back pain, for example. If we give an epidural for their back pain and it alleviates or mitigates, it decreases their back pain, sometimes they come back and their neck feels to them that it feels worse. It's not that their neck pain got worse. It's just that we've treated the back pain. Now the brain's focusing on the next pain. Then we would move to that pain as well. So we have different patients who we're treating for different sites of pain, which is actually very common. And we just strategically go through what is the worst site of pain. And we can also do different injections for different areas as well, as long as insurance is okay with that. But like I said, medications can be used to treat, doesn't just go straight to the back or right to the neck. It is done in the brain, and it will treat all various types of pain as well.
Yeah, I know too that as you age, you just generally develop more pain, more achy issues, or whatever. How does that fit? That sort of individual fit into pain management?
That's very common. Most of our patients are of the older population. I would say majority of our patients are 50 and up, because that's when pain develops. So we're very used to seeing patients like that. As we age, we do develop more pain, arthritis in different joints and different body parts, including neck, back, and various various joints. So this is very typical for our patient, our standard patient. And so we use the same approach as far as if you're having knee, just for an example, you're having knee pain, arthritis in the knee, we can do injections for the knee, ablations for the knee. If you're having it in your back, there's different procedures that we can do for that. And the point of the procedures is basically it can decrease the amount of medications that we need to take as well. And not just opioid medication, all the pain medications that are non-opioid as well. So a lot of patients, as we age, we end up taking more and more medications. And a lot of times patients, they actually want to come down off their medication. So if we do procedures that can help alleviate or mitigate that pain, they can actually come down off some of that medication as well.
So who provides care at Aultman Pain Management?
So we have, again, a multidisciplinary team, but we have 4 physicians and 3 to 4 nurse practitioners, depending on location and day, that are providing care. Again, multidisciplinary team, as mentioned before, is sort of our subsets, but the main providers are the 4 physicians and the 3 to 4 nurse practitioners.
So others staff too, beside physicians?
Yes.
No?
So
Yeah, okay.
the nurse practitioners, and then, like I said, we have, psychotherapists and physical therapists that we work closely with, as well as our nursing staff and intake staff.
So pain management provides therapy too, as well as medicine, drugs, and I mean, I can see it being a multi-therapeutic operation, at least from my side of it. So is that right?
That's correct. I mean, that's the best way to treat a patient, is holistically, not just problem solution.
Okay. I'm guessing we're time for a break, right, Brad?
Yep.
Okay. Bottom of the hour, time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning we are talking to Doctors Robert Dallara and Dr. Sarah Rogers.
All right. Well, I wanted to touch on something, in the pharmacy, sometimes over the past 30 years when I've been there, you think pain management, you think of opioids. And we all know that there's more ways to treat pain management than opioids. I wondered if, from a physician perspective, if you might care to comment on how you address the opioid crisis in our communities in your practice, while you still provide an effective treatment plan for patients to achieve their pain management goals.
So opioids are a good pain medication, but they're definitely not for everyone. I would say, at least in my practice, I do have some patients on opioids, but that's not the first thing that we go to. If somebody is having like acute pain, there's a few painful conditions that are very painful. They might need a short course of opioids even right off the bat, but that's not the case in the majority of patients. We try to do injections and other medications. There's tons of medications that you can use that are non-opioid, non-addictive, that don't have all the side effects of opioids for pain management. However, with the opioid crisis, in my opinion, it kind of swung from, prescribing a lot of opioids to really under-prescribing for some patients who actually do need opioids. So what we look at are risk, benefits, and alternatives for every patient. And that's different for every single patient. So you could have a patient who's high risk for addiction, misuse, and abuse. Well, you're not going to prescribe Medicaid because the risk is way too high for that patient. Where you have other patients where the risk is low of prescribing opioids and the benefit can be very high, where they have a better quality of life. And they can do the things that they want to do while taking these medications, and they're at low risk of abuse and misuse. So we don't normally jump straight to opioids in most cases. We will prescribe opioids for certain patients in certain cases. That's not the expectation of most patients coming in, I would say. And I normally set that expectations with patients when they come in, that's, I think pain management sometimes gets a bad rep that, pain management, all we do is write opioids, which is very far from reality. Actually, most of our patients are not on opioids. And most of our patients are managed well with the other modalities such as procedures and other medications.
I think you guys have a tough job because, I mean, I haven't been a pharmacist that long, but it's been almost 25, 30 years. And I feel like we had that time where the regular family practice or internal medicine doctor was terrified of treating pain because of the scrutiny of the regulators and things. And then you mentioned that maybe opioids are underprescribed in some areas, and you're probably familiar with the problems we had a couple months ago in the community where, because of the FDA challenges and restrictions, there were patients that couldn't get their medicines that needed them because they were out of stock and on back order. But I think it's also fair to touch on that not every pain responds to opioids, correct? So it's not really always, you already mentioned it's not appropriate for every patient, but sometimes an opioid isn't going to fix a patient's pain. So
that is true. And also some opioids are fast acting. So in general, we use the opioids for patients who, if they have moderate to severe pain, and then have other medications in the background to kind of treat their basal or kind of their general pain.
Can you touch on any recent advancements in pain management treatments or technologies that you've incorporated into your practice that you didn't have when you first got out of school?
Sure. So as we mentioned real early on in this interview, that there's, multiple new minimally invasive type treatments. So I'll give you a couple. We can talk about spinal cord stimulation and the advancements of neural modulation a little bit later if you'd like, but some basic things. Dr. Rogers mentioned that we both perform a procedure called MILD, which is actually like an arthroscopic lumbar decompression. So we're able to go in and actually remove the compressing elements on the spinal cord through a single stab incision versus a large surgical incision anymore. And that is very beneficial for patients with stenosis. It's almost a night and day type procedure. They have the procedure, and when they come in for follow-up, they may tell you, I don't know how much better I feel, but I know I'm walking a heck of a lot further, doc. And it basically is just an overnight thing. But again, without the major complications, because again, some of these folks are 80 years old and that they have multiple comorbidities. They wouldn't do well from an open surgery, blood loss being an issue, sugar being an issue, things of that nature. Some of the other things, a relatively newer thing is, as Dr. Rogers touched on, concept of ablation. That's been around for quite a while, but a new procedure out is basal vertebral nerve ablation, which basically treats chronic axial or bone pain of the spine. And that's a one and done procedure where we go in and we will go in and ablate the nerves inside the bones. It wasn't until about 4 or 5 years ago that it was recently known that the discs of the spine received their input from nerves through the bones. And we can go in and ablate those so that they no longer send any pain signals. And like I said, this is actually a one and done type procedure. It was actually in the news as a former talk show host had this procedure, and it changed his life. And he was only in his mid 40s when he had it done. So that is, one of the newer things. We also do things like minimally invasive joint fusions. Okay. Again, the concept here is to avoid the 4 to 6 inch scar and the adjusting of taking bones or things from the patients. Instead, what we're trying to do is augment what we have to allow the most natural anatomy to stay in place and maintain the patient while we treat the pain.
Interesting. What role does patient education play in your treatment plans, and how do you ensure that patients understand their pain management options and understand the fact that some work and some don't?
So patient education is very, very, very important. I think it's important to set expectations right off the jump for patients. Normally, they don't develop chronic pain overnight. Sometimes it doesn't go away overnight, but we work and do our best to get them to the point, like I said, that they have a good quality of life. Also, I think explaining to patients why they have the pain, reviewing MRIs with them, saying this is kind of what's going on with you so that they can understand in their brain. Sometimes it's very difficult if you tell a patient spinal stenosis
Yeah.
without showing them or explaining to them really what that means. So educating them and kind of also giving them the power as well. These are the things that you can do to help your pain. These are the exercises that you can do. These are the stretches that you can do. This is weight loss that you can do that can help your pain as well. So education is very, very important. We educate the patient when we're in the room with them. Also, the nurses help with the education as well before they leave to answer all their questions and make sure that they have all their questions so they understand not only what is causing their pain, but also what are the steps that we are taking moving forward. I think it's important for patients to know when they leave that this is the plan. I'm going to do this. I'm going to take this medication, or if you're not taking medication, I'm going to do my therapy. I'm going to do this injection. Then I have this follow up with the doctor. And that, I think it's very helpful for patients to understand also the game plan and have that in their head too.
Can you share an example of a particularly challenging case and how you approached it?
So, like I mentioned earlier, a lot of times we have these patients that are of advanced age with multiple comorbidities. Unfortunately, suffering from pain is not a guarantee to have surgery for the pain because of the complications related to having such surgery. So a lot of folks are in a position where a surgeon doesn't want to go in and do something, or they've even had multiple surgeries. And there's basically no other surgical options. Surgeons have said, there's nothing we can do for you. And, we would then go in and try one of our more interventional therapies, such as, spinal cord stimulation. I can particularly recall using a special type of spinal cord stimulation known as DRG for a patient that had multiple surgeries on their hernia that was no longer a surgical candidate, was of what I would consider generally poor health, but was still suffering from pain. And the stimulator was able to capture about 90% of the patient's pain in that area and allow them to have extreme quality of life.
Okay, it's time for our final break. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White, pharmacist Brad White, and I thank you for joining us. Let's get back to the last segment of the show. So, doctors, how do you manage patient expectations regarding pain relief, especially when full resolution of pain may not be possible?
I think you have to have that discussion with the patient. Expectation is really important. So, the idea of selling any falsehood will do nobody of any benefit, us as the practitioner or the patient. So you just have to have realistic discussions and expectations, as well as, like Dr. Rogers has pointed out, and I've even said before, we provide this longitudinal topic and discussion treatment plan for them so that they understand, one thing may lead to somewhat resolution. Give it a random number, 50%. Then we're going to go to the next thing and see if we can get, 60% by addressing that thing. And so, the idea is expectations out of the gate so that everybody's on the same page. As long as that is, what the expectations are, most patients are very happy with it. As Dr. Rogers said before, as we age and arthritis and things like that, pain becomes a real issue. But at least in my opinion, it's better than the alternative to not aging. So.
Well, why don't we cover some things about your practice here? We've got about 8 minutes left. Can a patient request to see a specific provider?
Yes, when they call up to when they call to make the appointment, or when we call you after the questionnaire and everything has been situated, if a patient wants to request a certain provider, they can do so.
I would like to add that some providers are only at certain locations on certain days. So if you are trying to get in the more quick type way, or trying to get in ASAP, as they would say, selecting your provider will probably delay that time. As Dr. Rogers is, only at this location, I'm at most other locations. As compared to Massillon, I'm only here a couple times a month, things like that. So bear that in mind if you are choosing your physician, but you certainly have that option.
Well, that leads me into the next question, which is perfect. Can you talk about your Aultman Pain Management locations?
Sure. So right now we have 3 locations. There may be plans to expand in the future. We have Aultman, Massillon, which is considered the main facility here. It's in Massillon, Jackson, down by Fulton. That's on 241. We also have Aultman Alliance Community Hospital, which has a pain management program there. And then we also have Aultman Orville Community Hospital, which has part of the pain management program there. All facilities are staffed by the same group of physicians that we discussed, in same group of nurse practitioners, and all treatments are available at either location. But those are the 3 locations for right now.
How do patients schedule an appointment?
The patient is going to be prioritized to location based on where they are, from like their home, but they have a preference if they would like to go somewhere else, for first available or more scheduling options. That's going to be known. The entire system is on one scheduling platform, so we can see who's got openings as first available and the like. But usually the plan is to keep it as close to home as possible for you.
What else would you like the listeners to know about Aultman Pain Management?
Aultman Pain Management is we're a growing practice, adding new providers and expanding our hours, and offering more procedures as we can. We care about the patients. We put patients first. We're here to help the patients. That's our main goal, is to help people and to help them to feel better and have a better quality of life. And that's our main goal here. And we try to do that any way that we possibly can.
Many years I've been a pharmacist for many years, and a lot of pain relievers have come out, and I can before my time, I can remember when Demerol came out, a little bit of understanding of it, at least. And many of the pain relievers, when they were brought out, they were told, the individuals and the doctors were told, well, they are not going to have your patient depend on them. And of course, the Demerol is a classic case many years ago that they put that drug out. Oh, well, it's not going to be, nobody's going to be dependent on it. And boom, they were right away. So in the last 10, 15, 20 years, have any remarkable products showed up that in the pain management that are not particularly dependent on the patient?
Well, I think a couple things, specifically to Demerol that, you're referring to. So Demerol is a neuroactive opioid. That was part of the problem with it being so addictive or dependent, as you will. Demerol is actually still used in the anesthesia world, even to this day, for post-operative shaking. So, even though it does have a bad rap, if you will, it does still have some utility. It's not used in the chronic pain space or in the frequency which what you're describing it was, a decade or so ago. But the specific part to Demerol is it does have a neuroactive component to it that made it such. Another very important distinction is the difference between dependency and addiction. So dependency is, a biophysical product of taking something for a long period of time, right? So that doesn't necessarily mean addiction. That's just that the body is used to having something and then displays dysautoregulation when it doesn't have it. And that can be said for even caffeine or nicotine or things of that nature. So it's not necessarily true addiction, but all of these drugs, as you guys are fully aware, are Schedule II medications, and the Schedule IIs are the most likely to be addictive or abused or misused. Now, to get to the meat of your question, there have been some newer things chemically that have come out. Most of those are in the very advanced form of pain management, such as intrathecal drug delivery. And then there's also been some new topical type things, such as high concentration capsaicin that has been used for neuropathic pain on the periphery for shingles, diabetic neuropathy, and the like. But opioids, there hasn't really been a new opioid itself that has come out in the last decade or so. However, there are some promising things in the FDA on the horizon.
Thank you very much, guest Dr. Robert Dallara and Dr. Sarah Rogers, Aultman Pain Management. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health Systems and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week. We'll see you right here next Friday on Newstalk 1480 WHBC.